Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. Today we have on the pod Marianne Amoss to talk about some recent federal rulemaking activity on the health policy front. But first, I wanted to let everyone know about Health Affairs released an ahead of print article this week. The article is titled Judicial Decisions Constraining Public Health Power During COVID-19, Implications for Public Health Policymaking. It is available to read online now, but it will be published in our June theme issue focused on reimagining public health. And now, Marianne, welcome to the program.
Thanks, Jeff.
Marianne, there has been a fair amount of activity in the rulemaking space of late. One of these is the final rule related to nursing staff levels. What's the top line of this?
Yeah, so back in April, the Centers for Medicare and Medicaid Services released the final rule that created new requirements for minimum staffing levels for all nursing facilities that participate in Medicare and Medicaid. And so they did this in light of a nursing shortage that the U.S. has been in the midst of for a while now, and it's expected to last until at least 2032. Basically, there are not enough nurses for a few reasons. There are low retention rates due to burnout and workplace violence. There's also an education gap, so there aren't enough nurse educators to train all of the nurses, all of the people who want to be nurses. And also, we have an aging population in the U.S. that is putting more pressure on nurses. So those are just a few of the reasons. But this focus on nurse staffing and staffing ratios, like the nurse to patient staffing ratio, has a lot to do with patient safety. So there's this documented risk of increased patient safety events, as well as morbidity and mortality as the number of patients per nurse increases. So this final rule that was just released last month creates a minimum staffing ratio across the board for all those nursing facilities. And it also requires that a registered nurse, also known as an RN, is on duty 24/7, so around the clock. Can I go into the nuts and bolts of this, Jeff? Is that good?
Yeah, sure.
All right, great. So they basically set up a system where the requirements are going to be phased in, and there are different timelines for urban and rural facilities. So there's an interim requirement deadline and then a final requirement deadline. So for urban facilities, by May 2026, they need to have at least 3.48 hours per resident day of total nursing staffing hours, regardless of staff type. Rural facilities have until May 2027 to meet that. And then for the final requirements, which urban facilities have until May 2027 to meet and rural facilities get until May 2029, these facilities need to have at least 3.48 hours per resident day, but that's divided specifically up between some of that time is for registered nurses and most of that is for nurses' aides. And that as well goes with hand in hand with having an RN on duty 24/7. I mentioned this term hours per resident day, and the way that's calculated is CMS will divide the total number of hours worked by each type of staff by the total number of facility residents. And the final rule also includes some new reporting and assessment requirements, some information about qualifying for exemptions from the final rule, and it also says that CMS will announce more information on a $75 million investment in nursing home staffing.
Marianne, thanks for sharing all that great information and data. It sounds like a lot's going on in that space. And as we know, no good deed goes unpunished. If you want to classify it as a good deed or not my space. Anyways, so there's a controversy around this. Is that correct?
Yeah, I think there are some people who would really agree with your sort of take on this, and some who would really not. And a lot of people have opinions. So the proposed rule had a public comment period, and it garnered nearly 50,000 comments, which I think is a lot by any measurement. So just to sort of sum up the two sides of this, the nursing home industry says that the rule is too onerous, giving staffing shortages, which I mentioned earlier, and the cost of building up the workforce. And that it could actually lead to nursing home closures, which we certainly, would certainly not be a problem.
Not great.
Not great. On the other side, resident and family advocates say that the rule is too weak to address quality concerns. So one side says it's too strong, one side says it's not strong enough. And lawmakers have gotten involved on both sides of this issue as well. So it's been really contentious. And the conversation is still continuing, even though the rule is now final.
Interesting. And so we have the for and against. And we have the final rule. So what was the administration's rationale with this, with going forward with it?
Yeah, I mean, I think that where they're coming from, many of us, I can speak from my own experience of having relatives in nursing home care and having concerns and issues with the care that they've received because of this staffing shortage. So the Biden administration released a fact sheet on this rule. And I'll quote from that. It said, when facilities are understaffed, residents may go without basic necessities like baths, trip to the bathroom, and meals, and it is less safe when residents have a medical emergency. Understaffing can also have a disproportionate impact on women and people of color who make up a large proportion of the nursing home workforce, because without sufficient support, these dedicated workers can't provide the care they know the residents deserve. So there are a lot of issues, a lot of serious issues of concern for many people wrapped up in this.
Check the pages of Health Affairs for any upcoming research on staffing levels and how this final rule might affect quality, spending, patient care, etc. Kind of shifting gears a little bit. There was also a new mandatory model that CMS released. This is the month of May, so it was this month. Can you tell us a little bit about that?
Yeah, that's right, Jeff. So it's a proposed mandatory model. And yes, it was just announced a few weeks ago on May 8th. It's called the Increasing Organ Transplant Access Model, also known as the IOTA model. And so it's being run by the CMS Innovation Center. And the goals of this model are to increase access to kidney transplants for people with end-stage renal disease, which is the final stage of kidney disease, as well as to improve quality of care for people seeking kidney transplants, reduce disparities among people receiving kidneys, and increase the capability and efficiency of transplant hospitals, all while reducing Medicare expenditures. So we sort of have a tall order here, but this again is a really important issue that affects a lot of people, because kidney transplant is really considered the superior treatment for people with end-stage renal disease. So as I mentioned, this is the final stage of kidney disease. And at this point, a person's options really are either dialysis, which is quite time-consuming and exhausting and depletes a number of different kinds of resources, financial and otherwise, or a kidney transplant. And people who receive kidney transplants generally have better outcomes than those on dialysis in terms of quality and length of life. The problem is there's a shortage of organs in general, specifically kidneys, and this supply-demand imbalance really has caused increased patient mortality as well as increased healthcare costs. As I alluded to, dialysis is more expensive than transplantation. The sort of complication here is at the same time, many donor kidneys go unused every year because of standards around quality. So a lot of kidneys just aren't able to go into patients that need them because of our standards for quality of donor kidneys. To sort of sum that up, as of March 2024, over 27,000 kidney transplants had been performed, but there were about 89,000 people on the waiting list for a kidney.
I'm curious, and maybe you know this, maybe you don't. Does this have any ties to value-based payment models or value-based care?
Well, yes, it does. And I'll get into that.
Okay.
Yeah. So I can tell you that the model is really designed to test whether performance-based incentives for participating hospitals can increase the number of kidney transplants from both living and deceased donors. It's also trying to encourage investments in care processes and patterns regarding patients in need of kidney transplants and spur investments in value-based care and improvement activities. So the answer is yes. The rule is really aiming to promote hospital accountability by tying payments to value.
And just for the listeners at home, this it wasn't as apparent to me that this was a value-based model when I was looking into it. But I will say it reminds me when CMS released other mandatory value-based payment models, especially for joint replacement. I don't know if you researched any of that, but that's just an interesting parallel of that CMS was releasing another mandatory model before I guess expanding it. Is that correct?
Yeah, and I think what they're doing makes a lot of sense. So they're requiring about 90 of the 257 transplant hospitals in the U.S. to participate, and basically they're doing that because they want to achieve I'm quoting from some of their materials, achieve a sufficient and representative national sample of participating kidney transplant hospitals. So they want to be able to measure the model's success. And I think that makes a lot of sense. I mean, if it's just a completely voluntary model, then you're not guaranteed to have the sort of the sample size that you need to really do a strong evaluation.
Yeah, I don't think it will surprise many of our listeners to know that the carrot is not as good as the stick when it comes to pilot programs in healthcare.
Right. Well, since I was delving into a little bit of the nuts and bolts of this model, I'll share too, Jeff, that this is a 6-year model. It'll start January 1st, 2025. The eligible hospitals will be those that are non-pediatric, that perform at least 11 transplants over 3 years. And these hospitals will be evaluated on the basis of increases in numbers of transplants and organ acceptance rates, as well as improved post-transplant outcomes. I do want to mention, too, if we can focus on inequities in kidney access for a second.
Please.
So access to organ transplantation varies geographically, but also it varies according to race, ethnicity, disability, and socioeconomic status. And racial inequities have received particular attention. I want to share the Scientific Registry of Transplant Recipients Annual Data Report noted that as of December 31st, 2022, Black individuals represented 32% of the wait list for a living donor organ, but only about 13% of transplant recipients, whereas white individuals represented about 36% of the wait list, but they were 62% of the recipients of living donor organs. So that's a pretty stark difference. And this model has some components that really try to address these health inequities. So the model includes a performance incentive for improving equity. So hospitals will have to create health equity plans to identify and address gaps in access to donor kidneys among certain populations. And hospitals also have this opportunity to address social drivers of health, like healthy food access, out-of-pocket drug costs, and transportation needs through the model. So I think that's an interesting component. That's what's worth highlighting.
Yeah, thank you. And just to quickly go back to the joint replacement model, I was doing some quick searching while we were on the call. The CMS had finalized the comprehensive care for joint replacement model way back 9 years ago in 2015, which is scary that it's 9 years ago. So it is interesting that CMS has building on these models where they've learned from that and then putting it to this model. And as you mentioned, it is proposed. So what can we expect next?
Right. So the public comment period is open until July 16th. So folks can go to the link that we will include in the show notes to make their comments. But I think it's worth watching this space. I think the Biden administration has really been focusing on organ transplant shortages and sort of these issues that this model is designed to address with kidneys in particular. And so I think it's interesting to watch the space and see if these efforts can really make a difference for the people who are waiting for donor kidneys.
Well, fantastic. Well, Marianne, thanks for joining us today, and hope you have a great weekend, and hope you, the listener, have a great weekend. Please tell a friend about this podcast. Let them know if they are interested in value-based joint payment bundle models, systems of care. Thanks, and have a great day.
Thanks, Jeff.